Good evening, everyone. I am RCDSO Registrar and CEO Dan Faulkner, and joining me is RCDSO Vice President Dr. Nalan Bhargava. I want to congratulate Dr. Harinder Sandhu and Dr. Nalan Bhargava on their recent election as President and Vice President by the RCDSO Council. I'm going to turn it over to Nalan to say a few words. Nalan.
Alan, you're muted.
Always fun. Okay, thank you. Thank you, Dan. Greetings, everyone. I believe we have over 800 dentists on this call tonight. And as many of you know, the RCDSO is the official regulator of the profession of dentistry in this province. However, we're also a resource for the dentists of this province. We have over 11,000 dentists and 9,000 dental offices or mini hospitals. So if we can do our part in helping these offices run better, smoother, and more efficiently, then that's part of our mandate as well. Hence the reason for this evening. So for this evening, two main takeaways. One, for those of you that stay to the end, you will earn one Category 1 CE point. Susan Taylor, Director of Quality for the RCDSO, will be on the call tonight and explain the logistics to you. And two, we're so thrilled to welcome the Canadian Society for Disability and Oral Health. And they've developed a tool, an algorithm which will help you in planning safe dental care for patients with disabilities. And as an added bonus, for those of you who use sedation in your practice, we've invited Dr. Daniel Haas from the University of Toronto to explain how you can use this tool to help with sedation. So thank you very much for coming this evening and enjoy. Dan.
Thanks very much, Nalan. I look forward to working with you, Harinder, and our new and returning council members over the next 2 years. Thanks everyone for joining our first RCDSO Connect session of 2025. Given the popularity of last year's sessions, we plan on having at least 6 virtual Connect sessions this year. Our aim is to use this platform to reach dentists from across the province, providing important clinical and regulatory information that is both timely and relevant. Topics for these sessions will include artificial intelligence and its application in dentistry, information about new standards of practice and guidance on important issues, including consent to treatment, professionalism, and IPAC, and updates on the divestment of the professional liability program. As the divestment process unfolds, we commit to sharing information and details with the profession all along the way. I encourage you to attend these Connect sessions, read our quarterly newsletter and email notices, and follow our social media channels to stay informed about changes to PLP. To be perfectly clear, it is business as usual with PLP. Your current coverage is not impacted and will continue throughout 2025. Please continue to reach out to PLP directly for advice or assistance. I would like to start today's session with recognition of the privilege of gathering online this evening by sharing a land acknowledgement. The RCDSO is on the traditional lands of the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Huron-Wendat peoples. These traditional lands are known to some as Toronto. Toronto is covered by Treaty 13 with the Mississaugas of the Credit and is home to many diverse First Nations, Inuit, and Métis peoples from across Turtle Island. This land is also part of the Dish with One Spoon territory, a treaty between allied nations to peaceably share and care for this land. We accept our responsibility to each other and this land we live and work on in a spirit of peace, friendship, and respect. We're committed to actively supporting the necessary work towards truth, reconciliation, and equity. We embrace our role in regulating dentists, in protecting the public interest, and strengthening our partnerships with Indigenous communities to advance access to safe and equitable oral health care. With that, I'm going to hand it back to Nalan to introduce our first speaker.
Thanks, Dan. This evening, I have the privilege of introducing Dr. Daniel Haas. I've known Dr. Haas for more than 30 years. In fact, I attended the University of Toronto Faculty of Dentistry, where Dan was my anesthesia professor and a great professor. Dan is a former faculty dean and leading expert in dental anesthesiology and pharmacology. He is currently a member of the RCDSO Council. Dan has been recognized for his significant contributions to oral health and dental education. His research on local anesthetic risks has enhanced patient safety worldwide. As Dean of the Faculty of Dentistry and an advocate for specialty recognition, he has influenced dental training and practices, again, worldwide. And last year, Dan was appointed a member of the Order of Canada, one of the country's highest civilian honors. It recognizes individuals whose achievements and service have had an impact on communities across Canada and beyond. Congratulations, Dan, and thank you for joining us tonight.
Great. Thank you so much, Alan, for the very, very kind introduction. Angela, I think we're ready for the slides. Great, and you can go on to the next slide. That's perfect. Thanks so much, Angelo. I'm very pleased to have been invited to play a small part in this presentation, and I'm joining you here for two reasons. One, I am a member of the Quality Assurance Committee of the college. Now, as stated in the Ontario regulation, one of the roles of this committee is to ensure the quality of practice of the profession. And the information that will be provided by my three colleagues this evening is certainly aligned with that objective. As well, one of the strategic plan priorities of the college is access to care. As dentists, we want to be able to care for all those in our community to the best of our abilities, because everyone deserves the opportunity to pursue optimal oral health. And again, this presentation is aimed at helping us achieve this goal. The second reason I'm here is that at the end of tonight's session, I'll provide a few very brief comments to consider if sedation is being contemplated for these patients. My own clinical practice had primarily consisted of adults with special needs who were referred to me as they were not able to tolerate dentistry while awake. So I'm very interested to learn, along with you, how to utilize this tool. Now, without further ado, it's my pleasure to introduce my three colleagues who will be providing this evening's presentation. And I'll introduce them in alphabetical order. The first is Dr. Clive Friedman, who is a pediatric dentist and professor at Schulich Medicine and Dentistry. Dr. Friedman has devoted his career to special needs dentistry, oral health education, and global initiatives, including sustainable dental care programs. He has published and lectured widely on oral health, risk management, and motivational interviewing, and mentors colleagues to implement practical resources that facilitate care. We also have Dr. Sharat Pani, who is the current president of the Canadian Society for Disability and Oral Health. Dr. Pani brings expertise in clinical pediatric dentistry and special care dentistry. His research interests focus on the biopsychosocial model of disease, combining epidemiology, behavioral sciences, and clinical pediatric dentistry. And third, we have Dr. Olaf Plotzke, who is co-founder and past president of the Canadian Society for Disability and Oral Health. Dr. Plotzke is a passionate advocate for improving oral health care access and quality of life for people with disabilities. In addition to 48 years as a practicing pediatric dentist, Dr. Plotzke served as faculty at Schulich School of Dentistry and has held leadership positions with specialty organizations. I'll now turn it over to you.
Thank you, Professor Haas. If you could have the next slide, please. So at the outset, as president of the Canadian Society of Disability and Oral Health, I have to thank the RCDSO leadership team for this wonderful initiative to help us bring this tool to you. Now, this tool has been in the making for at least 5 years, and what we look to present to you today is not a judgment as to should we be seeing more patients with disability in our practice. What we seek to present to you is a structure by which we can document and we can visualize what it is that enables us to see patients with special healthcare needs in our practice, what it is that enables us to refer these patients safely, and most importantly, what it is that makes us decide whether or not they actually need sedation to get optimal care. If we could have the next slide, please. So this is a continuing education course, and as mentioned before, it does carry one category 1 point. Next slide, please. And I do declare on behalf of myself and my two co-presenters that we have no proprietary financial or other personal interests or relationships relevant to this presentation that could give rise to a conflict of interest. And all images included in this presentation were obtained via public domain. And we'd also like to further stress that the tool itself is an open source document. It is, as we like to call it, a living and dynamic document that we look forward to sharing with all and improving as necessary. If you could have the next slide, please. So if we're looking at what we are hoping to give to our viewers today, one of the most important things that we want to get across is the importance of equitable access to oral health care and how a decision-making tool such as this can help us document and formulate a decision based on scientific fact. How to apply this tool, including an Excel-based resource which we've developed to make it a lot easier for us to use this in practice, and how to use it to assess case complexity and guide clinical care decisions, to define considerations for planning patient-centered care through the use of this tool in diverse care settings, to identify the relationship between sedation and risk based on insights on how the tool supports safer care by guiding a practitioner to the minimum required sedation level, and describe how we can take this tool forward and what are the next steps towards implementing this tool in practice. Next slide, please. So before we go further, we have to understand what disability looks like. And to this, I hand over to my colleague, Dr. Olaf Plotzke.
Thank you very much, Sharat. I also want to echo our appreciation on behalf of CSDH to the leadership team at the RCDSO and especially to Sue Taylor for all our hard work in facilitating this webinar. This slide I like to call by the numbers. It's a bit busy, but it was presented in December of 2023 by StatsCan following a 5-year study from 2017 to 2022. And it included Canadians aged 15 or older. And as you can see, that 27% of these Canadians represents 8 million people, but in fact does not even include any children of any kind within the boundaries of this study. On the right-hand side of the screen, you'll see the 10 defined disabilities that they calculated. And what we notice is that although mobility has the highest incidence, the greatest change of any of these disabilities happened to be in mental health, which had an increase of 3.2%. Of note is the fact that every one of these disabilities had an increase over the 5 past years. And what this means is that disability among Canadian adults is on the increase. And given these numbers and what we know about the limited access to oral health care, including the multiple challenging barriers for people with disabilities in Canada, I feel it's incumbent upon the oral health care profession to recognize that providing access to oral health care for people with disabilities is all of our responsibility. So that being said, let's now consider exactly what is disability. And for that, I'll return it back to Dr. Pani.
Thank you, Dr. Plotzke. Can we have the next slide, please? Yep. So if we look at disability, and if you, at the previous slide, it said that 27% of the Canadian population experiences some form of disability. Now, I just want you to stop a minute. Forget all the numbers, forget all the definitions, and I want you to think what 27% means. 27% means 1 in 4, which means if you were sitting in a chair and there was one person sitting in front of you, to the left of you, right of you, and behind you, one of those people would be having some form of disability. Now, you may think that seems very high. And the fact of the matter is that that is because we have to first understand what disability means to us. Now, to most of us, when we mention the word disability, we're thinking of the medical model, and that's because of the way we've been trained. when you look at medicine and the medical model views disability through its pathology. And this is important. Make no mistake. If there is an underlying medical condition that needs to be treated, it needs to be addressed first. It needs to be addressed for reasons of safety. And nobody argues that the medical model forms pretty much the basis of medicine. But there is more to disability than that. The functional model basically views disability as a person's ability to participate in activities. And this is the definition that the Canadian government uses, that the CRA uses to determine disability. And in many ways, the functional model is the core of what we are going to present to you today. This is again layered upon by the social model, which says that the society we live in, the social challenges and barriers that we face, also influence participation. So how does it all come together and how did it all begin? To understand that, we got to take a look at the next slide. Next slide, please. So if we look at the International Classification of Functioning, Disability and Health, or the ICF for short, this was adopted by all 191 members of the United Nations in 2001. And it stems actually from my own research area of biopsychosocial model of disability, which states that, yes, disability has a pathology. It has an underlying pathology. However, that is not the be-all and end-all. If you're looking at health, and health in any way, shape, or form, and this is not just oral health, health refers to a person's ability to participate in life activities. And if you view dentistry as a life activity, if you view the fact that dentistry is nothing but a person being able to sit and receive care in a dental chair safely, then the functional model assumes a whole different layer of complexity. So if you look at the health condition, there is the body function, there are activities that you can participate in, and there is the restriction of participation, each of which can then be influenced by the environment that we live in and personal factors. And my favorite thing about personal factors, as any pediatric dentist will tell you, is you take the same child one day, you take the same child another day, there will be a difference. And we've all seen our patients where that happens. But how does this all come together? And to do this, I hand over to the man who's had probably the most experience in Canada with this, somebody who's been involved with the functional model since its inception in the 1990s. So I hand over to my mentor, Dr. Clive Friedman.
Next slide, please. Thanks, Dr. Pani. So I'm going to just step backwards a little bit for you. The Canadian Dental Association have a number of questionnaires and pamphlets that are available to you. So to expand what Dr. Pani was saying with respect to the domains of the ICF, how do you collect some of that information? And some of that information we don't really have readily available in our current questionnaires, for example. So in the Canadian Dental Association, we actually created a number of specific questionnaires that you can give to your patients to determine some of those answers. So if we go to the next slide, an example of some of these questions could be related to, for example, the oral sensory profile of your patient. Now, you might think that oral sensory profile is specific to just, say, individuals with autism. However, it is equally important to individuals, say, with Alzheimer's or dementia. So you want to have a look at their ability to, for example, have toilet training or haircuts, what reinforcers are used, how they respond to brushing or to the sensitivity of even flossing, how their diets have changed, what their goals are. So we have in here specifically for children. However, it's equally important for the adult population with respect to what are the goals of an individual who is in palliative care with respect to oral health. So we have to be able to provide an evaluation of that individual, taking into consideration all of these issues. The next slide, please. Which brings us to what does this mean in practice? And what I just spoke to you about in terms of oral sensory profile really is a small part of the questionnaire that you can have, and I'm going to let you access that questionnaire yourselves to have a look at the expansive information that you can get. So what this does is it enables us as practitioners to create a true dental home for individuals where we can improve communication, we can improve our diagnosis, and the diagnosis becomes a process of really improved treatment planning with that individual taking into consideration all of those dynamics. Next slide, please. Which brings us to the beginning of the case complexity. So when we're having a look at case complexity, the primary reason for doing this, I think, is that we wanting to evaluate not necessarily the medical diagnosis of an individual, but using all those 5 domains, what aspects of this person's life will make treatment more complex, will make treatment take longer, will make it require us to have different environments in order to be able to provide care. And this is not necessarily necessary specifically so that you're going to identify an individual as complex so that you can automatically refer that individual, but it might mean that you can actually identify what knowledge base is it that you need in order to be able to provide care for that patient. Next slide. Next slide, please. So in order to apply this, let's have a look at an example of a patient. And this is an ideal case that was developed by the IADH, the International Association of Disability and Oral Health. And it's just an example of a case. So we have John, who's 42 years of age. He has Down syndrome. He works as a waiter in a cafe. He lives with his girlfriend. He enjoys engaging with customers and has sufficient communication skills to take orders and interact with those customers. He did undergo cardiac surgery as a child, and his physician does advise antibiotic prophylaxis for SBE. He's had a poor past experience with dental treatment as a child and is extremely nervous in the dental office. His dad drives him to appointments, but he brings his girlfriend along for support. His lower incisors are mobile, and he lacks the motor skills to perform good oral hygiene. He does have ODSP, but his parents can cover additional costs. So let's see how this fits into that schema that Sharat showed us. Next slide, please. So using this schema, you'll be able to see how the interactions between all the components interplay, and how the individual functioning in a specific domain is a complex set of interactions between the health condition and the contextual factors of this individual. So if you have a look at under body structure function, I've identified the cardiac defect, that he needs SBE prophylaxis, that he has a class 3 malocclusion, and he's got early onset perio. Next, he has a difficulty with brushing because he doesn't have any fine motor skills, and he has an inability to eat hard food in terms of his activity. He does work in a local cafe. He lives in his own apartment with his girlfriend. So these are things that you can start to take into consideration when having a look at the individual. The personal factors, he is literate, but he takes everything literally. This is not unusual in individuals with disabilities, and he may react to criticism negatively. And it's important to identify these kinds of things because we're so used to giving oral hygiene instruction, for example, and not aware of the impact that that might have on an individual. And then, of course, there's the environmental factors that really look at all of the aspects that are going to improve or not improve his ability to access care. So things like ODSP, and in his case, he has a parent who can help him, and that is not often the case. So beginning to take all of these things into consideration and using them in the tool is going to, Sharat is going to show you how we do that.
Thank you.
Next slide, please.
Right. So at this particular point, if you look at what Dr. Friedman was just telling you about where you are with a patient with disability, you can essentially condense all that information into set domains. Now, if you look at a rubric or a tool or a quality assurance measure, you can call it what you want to call it. But in a sense, there are two things that a busy practitioner really wants. One is, of course, we want something that will help us treat our patients safely, but we also want something that can be done quickly and with a reasonable amount of time. We don't want to say that something's going to take us half an hour to just fill in a tool. So was there a way to bring it all together? So I'm just going to deviate a little bit towards the history of this tool. So we weren't the first to develop the tool. The tool was originally developed in the United Kingdom because the NIH, the NHS wanted a tool that could document how much time general practitioners and specialists were spending on patients with special healthcare needs. So they came up with this initial tool and said, wait a minute, there are 5 domains, and these domains have been identified in the UK, they've been used in France. So the content validity of this tool is pretty strong. It's been validated across the world. So if you look at any individual, complexity begins not with the medical component, but very often with communication. Can you actually communicate? Which is what Dr. Friedman was kind of alluding to. With John, how you actually communicate to somebody who takes things literally. What are your barriers? Because you may have a barrier or you may not have a barrier, but these are things to take into consideration. Secondly, the behavior, the medical problem itself. So for example, that cardiac condition that John has, is it something that is controlled or is that something that's unstable? Do we need to take extra precautions? What is the extent of dental treatment need? And most importantly, what are the other factors affecting John's access to care? Now, these are then scored as mild, moderate, or severe factors, and those are given a numerical score. What we've done is we've taken the questionnaire, which is available through the CDA website, attached an Excel sheet to it, and I'm just going to take you through each of these domains for John and how the scoring can be done, and it can be done relatively quickly. Next slide, please. So the first domain is, of course, communication. And you can see, is it good communication, difficulty in communication? Is it a language barrier? Is it a learning difficulty? Or are there complex natures, such as, the multiple communication aids required, moderate learning difficulty, or severe communication difficulties? And you can notice that the complexity here has nothing to do with medical complexity, or does not necessarily mean that just because something is complex, you need to sedate somebody. The decision and the rationale here is, how can we, as Dr. Friedman mentioned at the beginning of the lecture, and as Dr. Plotzke mentioned at the beginning, how can we actually become better at communicating, right? So let's see how John scored. So next slide, please. So if you look at John, basically a weighted score of 1 was placed for good communication, and the Excel sheet automatically scored that as 0. And an overall communication score of 0 is what John got, which means that there is not much complexity with communication. Next slide, please. So next thing is behavior. So when it comes to behavior, is it that the patient is completely stable from a behavioral standpoint, or are there complexities here? And if you look at the next slide, please. If you look at his Excel chart, you will see that definitely John, and if we didn't have, I don't know if you had time to read while Dr. Friedman was explaining the case, John had a bad experience as a child, so he's always been nervous in the dental clinic. Now, the fact that John has Down syndrome is secondary. He's nervous just as are so many of our patients. And a lot of these patients are nervous, but what are they nervous about? Are they nervous about a needle? Are they nervous about a procedure? So you can see here, John scored 1 in a moderate, which is basically that a full examination is possible chair side, and therefore a weighted score of 3. There could be some individuals, not like John, where only a limited examination is possible, or it may be virtually impossible to get the mouth open. Again, if you look at this, yes, one of the factors of complexity in behavior is the need for general anesthetic or sedation. And Dr. Haas will talk about it at the end. But that is not the only complexity. Are there ways that we can actually examine a patient without sedation? Complexity has layers, and what the tool essentially allows a clinician to do is it allows us to actually put down paper on pen, or rather in this case, Excel on iPad, what it is that's stopping us from actually taking a look, right? So let's take a look at the next one, please. The next domain is the medical history. And if you look at John's medical history, this is always an interesting one, because patients with Down syndrome could be stable, could be seen in a clinic safely, or they could not be, depending on their medical history. So is it, of course, it's not non-contributory, but where are they? Where are they on this? So if you can take a look at the next slide, please. Yep. So John scores is basically he's able to manage his medication and appointments independently, which means that, yes, there is a complexity, but that complexity is very manageable. And that is very different from somebody with an unstable condition who would need to be hospitalized. So as you can see, again, complexity does not necessarily mean hospitalization. Complexity does not necessarily mean sedation. However, sedation and hospitalization are definite indicators of complexity. And it's a twofold street. And we'll come back to this at the end of the presentation a little more. If we can have the next slide, please. And this, for me, as the dentist, as the care provider, is perhaps the most important feature, because what is the extent of dental treatment care needs that John has? Does John just need a cleaning? Are we going to extract those teeth? Are we going to do implants? What is the extent of John's care? And if you can have the next slide, please. You can see that from the original case, John was unable to, he was losing dexterity. And this is such an important part of case complexity that we need to document it. How many of our patients are losing their oral health, their oral wellness, because of challenges in maintaining dexterity? And this is an age-related thing as well. And it is complexity. Similarly, there is a malocclusion that's developing partly because of his underlying condition, where there is an increase in pathology. And he has a cariogenic diet. Yes, they say, there is less caries, but he has a cariogenic diet and he has caries risk. So overall, John scored a 9 here. And then if you go to the next slide, what about his access to care? And here, if you go to the next slide, please. If you can change the slide. John actually is blessed because he has ODSP and he has parents who are willing to chip in the little extra. So from an access to care perspective, John has access to care. So John scored 15. So what the CSDH did is we tested this amongst our experts. We tested this amongst our providers who are seeing patients with disability, both children and adults. And basically we said, is there a sort of a mathematical way to look at this? Or do we want to look at it as complexity or no complexity? So if you put the next slide up, we came up with this case range based on what our experts saw. And we saw that if you had a patient who had 0 to 5, pretty much you wouldn't notice a complexity. You would be able to see this patient. 5 to 25 means that there is a moderate complexity. Yes, you can attempt treatment with caution, but you may need additional support, training, or mentorship. And we're going to address this at the end of this lecture. And the most important, complexity is defined twofold. One is numerically, that's it. I'm overwhelmed. Like I'm not hitting red in any one of the individual domains, but there's just so many of these complexities that I'm overwhelmed. It's 26 and above, it's a complex case. Or, and this is an important or, any one of those domains, you hit a red signal where you are no longer comfortable providing safe care. And I think this is an important thing. And I know that Dr. Friedman, Dr. Plotzke will speak more towards this, because as they train students in the school, they notice this, that a person's definition of complexity changes. If I can have the next slide, this is an important slide. We did it amongst 2 expert examiners, and you'll see that if it came to communication, their scores were pretty much aligned. They were very close on John. But where the variation was most marked was when it came to dental treatment need, because one examiner saw it as a 3, one examiner saw it as a 9. And this to me brings me to an important topic for which I'm going to hand it over to Dr. Friedman. And that is, what exactly is dental treatment need? Who determines it? Is it me? Or am I listening to my patient? Because a lot of, just because a patient has disability doesn't mean a patient doesn't have a voice. Every patient has a right to participate in their decision-making process. And to talk about patient-centered care, I will hand over to Dr. Friedman.
So next slide, please. So I'm hoping that at this juncture, you're getting the idea that complexity is not predicated on the medical model. So you can have two individuals with Down syndrome, and one could be easy and one could be extremely complex. So it's not predicated on the diagnosis per se, but it is predicated on, for us, a patient-centered approach to care. These are just a number of examples that Chris Bedos wrote about in the OASIS discussions in 2020. And it really speaks to the issues that we need to consider when looking at patient-centered care. And things like not being judgmental or being humble and respectful for an individual, which are really important when we're looking at cultural safety. Things like it's important to explore all aspects of a person's life, not just think about, well, they have Down syndrome and what are the things that happens with the individual with Down syndrome. And you can expand that to any medical diagnosis, if you will. So there are a number of things that you can have a look at in terms of patient-centered care. And what I think this complexity document does for us is it reminds us to look at those issues. Next slide. So I'm going to hand this over to Dr. Plotzke now, that he'll discuss some of the advantages of looking at documenting complexity.
Trying not to be disruptive. When we look at this particular list, what we notice is various elements to the documentation. And the first item that you see is documentation itself. And what I take from that translates into a collection of data. The problem currently in Canada is there is a virtual dearth of data. There is nothing specific. There's nothing that's being collected that specifically relates to collection of data of access to oral health care as it relates to people with disability. We can go on for hours regarding what this particular policy means, but that's not the point of this particular lecture. The data collection, if we don't have it, my concern is how can we hope to establish what the problem is in order to develop strategies to solve the problem itself? With the collection of data, we can determine the treatment outcomes and therefore be able to shape the policy about how to best solve some of the current barriers to access to care. And of course, these would include things like provider availability, geographical problems, physical problems, infrastructure problems, lack of education, and all of those barriers that have brought us to this point. The data collection will also provide quality assurance for provincially funded programs such as Healthy Smiles and ODSP, along with the federal Canadian Dental Plan, by assessing and determining if these programs are providing access to care for all of the people that these programs were meant to serve. Going through the process of completing the case complexity tool will provide a form of self-assessment for the entire oral health care team. Reviewing patient information and utilizing the tool will permit the team to determine if some type of training is all that's really required, permitted to provide initial appropriate care. This may result in the patient to not only be able to establish a dental home, but perhaps even avoid things like significantly difficult forms of treatment, which would involve things like moderate to deep sedation or even general anesthesia. Collection through appropriate documentation of data will improve awareness by oral healthcare providers of issues related to the access of care in determining where these deficiencies currently exist. Now, as we've seen, which may become more apparent with Dr. Haas's comments, the completion of the document will also help direct treatment approaches with regard to determining which patients may or may not require sedation or treatment under general anesthesia, or if in fact something as uncomplicated as desensitization, which suggests it would require a little more time, but this may be all that is required to complete the initial necessary care. Finally, taking the time to complete the documentation will significantly improve communication and provide more clarity with and in between the patient, the clinician, and/or the entire team. So let's now look at next steps in the process. And with that, I'll turn it over to Dr. Pani.
Thank you so much, Dr. Plotzke. And, I was just following the chat here, and some of this has actually come up in the chat. So, for example, how do I actually recognize the extent of complexity? Do I need to refer, and to whom do I need to refer? And at this point, I really want to look at it from the view of the tool, because, it is starting out. It is a dynamic tool. We're hoping to grow it. Couple of points. One is somebody raised the point of how are these weights actually calculated. The weights are based off the British model. And it's really interesting to see how the British approached it, because they approached it as a numerical value, right? And so if complexity means more numbers means more complexity. And that is one argument. There is a counter to that, which the French have come up with, and which I think Dr. Friedman was trying to also explain when he was talking about complexity being more than just one domain of complexity, right? And that is, if there is something that I am uncomfortable with, then that means that that patient is complex to me. So what the tool allows us to do is it identifies which are these areas where we can improve this. And what we're hoping to do is to work with the college to create a mentorship program so that these specialists, because we are not a specialty, it isn't a specialty in Canada. We're not assuming to be specialists in this field. We're just assuming to be people who are competent at providing care to individuals with special health care needs. And within that, basically, how can we create a mentorship program so that you can reach out to mentors who can help deal with patients with special health care needs? The more important thing for me, and this is again coming back to the score, how does a score help? Unfortunately or fortunately, scores help when it comes towards complexity of the treatment plan. So for example, a greater score would help us document it. These need large long-term validation. And I believe Dr. Friedman, Dr. Plotzke raised this at the beginning. And we said, we all need data. We all want data. We all want to go further. And we say, we want to analyze data. But bottom line is, we don't have a basis for that data. And what we're hoping to create with this tool is the ability to create a CE course, to create mentorship, to get people to use it and see how easy it is to use, so that we will have a source of data so that we can analyze it and we can improve it. If I can have the next slide, please. So really, before I hand over to Professor Haas, I thought I'd come back to this diagram. And this diagram is something that's very close to me, because the original one was actually developed by one of my mentors, Professor Alison Dougal. She was in the United Kingdom. She was responsible for the original tool. This has been taken a lot from that. And when we look at complexity, one of the things that we look at in complexity is that it's not static. That yes, you have this red complexity, which states that, for example, in some patients, all procedures are complex, and the tool helps us clearly realize who these patients are. But there are some patients for whom only certain procedures may be complex, whereas for the rest of them, they could go between routine and moderate care. And the question that we really need to ask ourselves before we think of safe sedation is, does the patient really need sedation for care? And do we need to use sedation for a certain standard or quality of care? And I think they're two separate questions, because there is, of course, sedation to be able to look inside a patient's mouth and perform care in the patient. And what are the sort of procedures where we would definitely need sedation to provide a quality or standard of work that was acceptable? And I believe this brings us to the end of our part of the presentation. And with that, I hand over to Professor Haas, because I do know that when it comes to sedation, he's the man. So that's all yours.
Thank you so much. Next slide, please, Angelo. Great, appreciate that. So we will now turn to what should we do if the decision-making leads to a consideration of sedation or general anesthesia? And it can be helpful to try to simplify it down to answering just a few basic questions. As mentioned before, first, is sedation necessary to enable safe and effective care? And here the tool just described is extremely helpful in determining the answer. I mean, if the answer is no, clearly we don't go down that path. We have many expressions in anesthesia, and one is the best anesthetic is no anesthetic. So obviously only proceed down this path if you feel it's required. On the other hand, if you've determined that yes, sedation is required to enable care, then we need to ask ourselves, what is the patient's cognitive ability? Will they accept a procedure being done while they are conscious? If that answer is yes, we can then consider minimal or moderate sedation. But we need to be sensitive to the fact that the altered sensations that accompany minimal or moderate sedation, such as the lightheadedness or the floating feeling that many of us might get, things that we find relaxing, have the potential to be very upsetting to others who have a different cognitive level. That patient might still not understand who we are and what we're trying to do as we hold our dental instruments in our hands. And in turn, this can then lead to less cooperation, not more. If we believe that that's the case, then deep sedation or general anesthesia is required. And depending on your own practice situation, either arrange for someone to come in to provide this for you if you have the appropriate facility permit, or refer out to a specialist. Next slide, please, Angela. Further points that we need to consider include whether there are comorbidities that could increase the risk of administering sedation. We would determine this from our medical history and this tool. What ASA classification did you assign to this patient? This will help guide our decision whether to do the case ourselves or refer to a specialist. Appropriate patient selection is essential in keeping sedation as safe as possible. Another question to consider is whether there is appropriate care at home postoperatively. When discharging the patient, if the caregiver is driving the car, is there a second passenger there whose responsibility is to keep an eye on that sedated patient? Overall, we continue to balance the risks versus benefits of administering sedation before deciding to proceed. And if you're unsure, then refer out. Next slide, please. The key to keeping this safe is to stick to basics. Everything that you learned in your course teaching you sedation applies. It's essential for us to understand the differences among the 4 different modalities. Always remember that it is so easy for the patient to cross the line and drift over from moderate sedation to deep sedation. But if that happens, it's a quantum leap in the necessary training and the requirements in minimizing risk. You need to know the RCDSO standard and what is required and what responsibilities you have. Next slide, please, Angela. So to summarize, sedation is an extremely valuable modality that can enable safe and effective care. And its judicious application can increase access to care. But we have to respect the limits of these modalities. Don't be tempted to push a technique beyond what it is intended to do and what you're qualified to do. In other words, don't go from a conscious technique such as minimal or moderate sedation to deep sedation if your training is only for minimal or moderate. We have to accept the reality that for many patients, sedation might not be appropriate. And if required, never hesitate to refer to someone who is qualified. And with that, I want to thank you for listening, and I will turn it back to Susan.
Thank you, Dr. Haas. And thank you to all of our panelists this evening. I think we've had a really wonderful presentation, and a number of things have really jumped out at me. But I'm watching the time, and I actually think we have time for a question. We've been watching the chat as questions have been coming in. And there was a question from a participant that was around, what do you do if a patient requires general anesthetic for exam, cleaning, and so forth, but there's no one in your community that you can refer them to? And I wonder if maybe we can start with one of our presenters from either Dr. Friedman, Plotzke, or Pani, and then maybe Dr. Haas, you may have some comments as well. We have about 3 minutes for this question.
I'd like to actually start off by saying that, we receive a lot of referrals for, patients with special healthcare needs. And over the years, I know that there are some practitioners, especially if you're hospital-based or anesthesia-based, you receive them for sedation. And I was just discussing this with Clive and Olaf. I said, maybe it's because I'm younger, maybe because I just started out, and people feel, okay, why don't you just take a look? Over 80% of my referrals are actually, why don't you take a look, referrals. It's not this patient needs sedation, why don't you take a look, referrals. And I'd like to start by saying that very often being able to look inside the patient's mouth is the first step. There was one patient who'd been through a couple of dentists, each person saying, she needs sedation, on a wait list, in a wait list, off a wait list, came in, and all I was able to do was use a simple mold mouth probe. Patient opened the mouth, took a look inside, and there was no cavities in the mouth. And then, we worked with the patient, and turned out that a cleaning was all they needed. And at that point, they didn't need it. Now, I'm not saying that is reflective of every patient who comes in. There are definitely going to be patients who need sedation. And I think that part of the debate I'm going to leave to somebody else to answer. But all I would like to say is, I think the first step is, have we looked in the mouth? Are we able to look in the mouth? And I think one of the things that the CSDH and the I learned some of these through the IADH. I know Clive and Olaf, again, have been associated with the International Association. And in fact, the Europeans have done this much better, I feel, than us, is they've come up with simple devices and mouth probes that can allow a person to look at the patient in their comfort zone. And that does not necessarily have to be in the dental chair. And I believe that the first step has to be to take a look. And, after that, yes, of course, there are going to be patients who need referral for anesthesia, and I'm going to pass that question along. But I think we need to first deal with this large proportion of patients who did not need anesthesia. So,
okay.
Right.
Okay. Thank you, Dr. Pani. I wonder if there's anybody else from our group that would like to add to that.
I'm not sure if I can add to it, but I've just gone through the chat, and the scope of the questions are basically all over the place. But the best way to consolidate them is to say that you folks are all addressing barriers. And these are the barriers that we are trying to break down. We can't do it overnight, but certainly we are making steps and making progress, both with academic environments, with government funding, with efforts as far as research, with this kind of program, providing continuing education, having material on the website. There are specifics that we cannot change. For example, very briefly, the one person who asked about oral health care provided by OHIP, that's a government decision. That's not our decision. Those are the kinds of questions we really can't answer. The other one, of course, is the fact as far which specialist to refer to. And we all know there is no such thing as a specialist for special needs, but there are people that have extra training. There are gratefully still some pediatric dentists that will consider and continue to see people growing into their adulthood. That's their choice, and we applaud them for it. We don't have every answer, and I apologize. I know there are many of you out there that are looking for it, but we are available, and you can reach us through our website, and then hopefully be able to offer the time to answer your questions more appropriately.
Okay, thank you, Dr. Plotzke.
I'm going to just add one thing here, Susan, in terms of working with individuals with disabilities and special needs. I think it's an opportunity for people to really step outside of their comfort zones and step outside of the so-called norm with respect to how I do things, what do I do? So when you have an adult individual who you say you cannot evaluate, are there other ways to actually look at such an individual and You know, there are many options that we have that you might not have thought about. And I think that's where the mentoring program that Susan's going to talk about can really start to give you an idea of how can I access something that maybe I wasn't thinking about that is actually quite simple.
Great. Thank you, Dr. Friedman. So with that, and I am mindful of time, I do really want to thank all of our presenters this evening, Dr. Friedman, Plotzke, and Pani, for their work around the case complexity assessment tool, and then of course Dr. Haas for his expertise around sedation and how does this fit together. I'm really struck by one point in particular, and that was Dr. Pani at the very beginning talked about if you were sitting in a room and you looked at the person in front of you, behind you, to the left and to the right, and that one of those people would have a disability. And so it's not just the people who maybe have lived with a disability all of their lives. It could be people as they age, as you can see from my white hair, many of us are. So thinking in that perspective, but just generally speaking, how can we help? How can we really help clinicians, dentists, have a good conversation with their patients and their family members to really plan that care and make sure that the referrals, if need be, are made when they need to be made. But if you can provide that care, that you've got that confidence to do so. Just in terms of next steps, you'll see on the slide that's on the screen now, for people who have stayed with us tonight for at least 40 minutes, it's a Category 1 course. You will get a Category 1 certificate. There is no code. That is in our ongoing effort to make things easier. We no longer require a code. What we will do is pull that information from our Zoom records for tonight's call, and we will send the certificates out automatically to you within the next 5 business days. So between now and next Tuesday, you'll get an email from us that has your certificate attached. That certificate will also, or that email will also include a link to where you can find the recording from tonight's session. And we really encourage you to share this recording with your colleagues. One of the best ways to get traction at a practice level is to have everybody on the same page. And so if you share the recording with your colleagues, they may be dentists, they may be others in your team. If they are dentists who watch the recording, they can earn Category 3 point for the recording, and others, it just helps them to have that information. We will also include a link for self-study where you can earn up to 5 points in Category 2 for implementing various aspects of the case complexity tool that we've talked about tonight, and thinking about how this links into our sedation standard. And then as Dr. Friedman and Plotzke and Pani have mentioned, we are looking at mentoring and how can you share your experience and expertise with others, and how can you draw on the experience and expertise of others. So there is more information that we'll include there, so that you can share that learning and use that learning to earn some additional Category 2 points or 3 points, depending on the case. So with that, I will pass it back to Dan Faulkner, who is our registrar and CEO.
Thanks, Susan. Thank you very much for your leadership in building our quality program and supporting dentists and their practices in so many ways. Tonight's session was absolutely top-notch. And to our presenters, Sharat, Olaf, Clive, and Dan, thank you so much for sharing your work, your passion for this work with the RCDSO Connect audience tonight. RCDSO is really excited and proud to bring to Ontario's dentists practical clinical knowledge and advice that ties so well to our strategic goals, and in this case, patient access to care and health equity. I hope that many of you are able to adapt elements of the case complexity assessment tool in your own practice and share the tool with your oral health teams to improve their confidence in providing person-centered care. The college will continue to promote continuing education that helps you obtain CE points and, more importantly, leads to positive changes in your practice. There have been so many great stories that we've heard that have come to our attention following last fall's session on choosing wisely and antibiotic prescribing. And I hope we get similar stories following this session as well. As always, if you do have any practice-related questions, please reach out to the staff and the college's practice advisory service by email at practiceadvisory@rcdso.ca. rcdso.org. You can also follow the college's LinkedIn and Instagram accounts to receive our latest news, updates, and resources. We'll be sending you an evaluation survey, as Susan said, about this evening's session. It's short, and it will help us understand how we can make future RCDSO Connect events more valuable for you. For those of you who have joined previous Connect sessions, we're not going to, we will not ask for an event code. We will use the email you provided this evening for the Zoom session to send your CE certificate, and you heard that from Susan as well. You can expect to receive it early next week. Our next RCDSO Connect session will feature Dr. Peter Fritz, who will speak about the transformative nature of artificial intelligence in dental practice. We hope you can join us on March 4th for that exciting event. Look for an RSVP email from the college next week. Thank you again, everyone. Thank you, presenters, for joining us, and please enjoy the rest of your evening.